All right, so let's get started with Chapter 17, Part 1, Respiratory Emergencies. Let's see what we got going here. So when we think about the calls that we respond to in EMS, respiratory issues are some of the most common ones that we respond to. So whether it's difficulty breathing, asthma attacks, or more severe conditions, those respiratory problems, they're part of what we deal with on a daily basis. Now let's talk about the epidemiology of some respiratory emergencies. So, how common are respiratory diseases? So respiratory conditions, they're a huge concern, and that's both in terms of how many people are affected and then how serious they can be. So when we talk about these, let's just look at a few of the most common ones. So we'll look at asthma and COPD. And these two conditions, they're not only some of the top causes of disability, but they also contribute to many deaths around the world. So in the US, around 16 million people suffer from COPD, while about 25 million Americans have asthma. And then let's look at pneumonia. That's one of the most common causes of death worldwide, especially in developing countries where access to health care might be limited. So it's a major concern for both adults as well as children. Now, respiratory diseases can come from different sources. Some are genetic, so what we call intrinsic, meaning they're inherited or caused by internal factors, like in the case of some types of asthma or rare lung diseases. And then other respiratory problems are caused by external or extrinsic factors like environmental pollutants, allergens in the air, lifestyle choices such as smoking, things like that. So things that we often can control, like our environment and habits, those things can play a big role in whether we develop respiratory issues. Now let's do a quick little A&P review. So when we think about the primary structures of the airway, we want to think of kind of an upside down tree, if you will. So just to help you kind of visualize it. So the trachea, it acts like the trunk of a tree, and it's the main airway that brings air into the body. And just like a tree trunk, it supports all the branches. So the trachea supports the smaller air passages that branch off from it. Now from the trachea, we get to the bronchi. And these are like the main branches of the tree. And as the bronchi get smaller, they split into tinier branches called bronchioles. And just like how smaller branches grow off the main ones. And at the very end of the bronchioles are the alveoli, which are like the leaves of the tree. Now these tiny little air sacs, these things are where the magic happens. So oxygen comes in, carbon dioxide leaves. This is where that gas exchange takes place, just like leaves help exchange the gases in plants. So let's talk about the trachea and how it fits into the whole respiratory system. So think of the trachea as the main highway for the air to travel from the outside world to the lungs. It's the trunk of the tracheobronchial tree. It's about 4 to 5 inches long, extending from the larynx, so from the voice box down to where it splits into the left and right main stem bronchi. Now that's where you have that bifurcation, where it splits. So the trachea doesn't go straight into the lungs. Instead, it splits or it bifurcates at a point called the carina, and that's at around the level of the 5th intercostal space. That's, between your ribs. So now the right main stem bronchus, it branches off at a more shallow angle than the left. So this actually makes it more likely for things to accidentally go into the right lung. So like when food or liquid goes down the wrong pipe and it causes aspiration. Obviously from intubation, you should know also about the right main stem bronchus as well. So the bronchi are the airways that help direct air into the lungs, and then they keep branching out into smaller and smaller tubes as they get closer to the alveoli. So after air travels down the trachea, it divides into the right and left main stem bronchi, and these are like the main highways that take air into the lungs. So from here they branch out to different parts of the lungs. So you have the lobar bronchi, and these are the secondary bronchi that lead to specific parts or lobes of the lungs. So the right lung has 3 lobar bronchi for the upper, middle, and lower lobes, and then the left lung has 2 lobar bronchi for the upper and lower lobes. And then next, the lobar bronchi split into the tertiary bronchi, and that's also known as the segmental bronchi. and these bronchi take air to the specific segments of each lobe of the lung. And then as the segmental bronchi keep branching out, they form smaller subsegmental bronchi. So these lead to even smaller airways before becoming bronchioles. And then bronchioles, those are the smallest airways in the lungs that still carry air. And these tiny little airways eventually lead to the alveoli. And that's where that crucial gas exchange happens. Now, in certain respiratory diseases, we talk about dead space. So that refers to the parts of the airway where air travels, but it doesn't get to do anything useful, like exchanging gases or anything. So if dead space increases, which can happen in conditions like COPD or asthma, it can mess with how efficiently oxygen is absorbed and carbon dioxide is removed. Now let's take a closer look at the respiratory bronchioles, and they play a key role in getting air into the lungs where the gas exchange happens. So those respiratory bronchioles, they're the last stop in the tracheobronchial tree before we hit the areas where actual gas exchange takes place. So they mark the shift from just moving air into the lungs, so kind of the conducting zone, to where the lungs actually start swapping oxygen and carbon dioxide. So that'd be the respiratory zone. Now these bronchioles are a bit special because they're the first place in the airways where you start to see alveoli, and these tiny air sacs that are so important for gas exchange. So the respiratory bronchioles branch off from the terminal bronchioles, and then they lead to the alveolar ducts, which then connect to the alveolar sacs. Now the main job of the respiratory bronchioles is to help with gas exchange. So the alveoli in the bronchioles let oxygen from the air enter the blood and help remove carbon dioxide from the blood so it can be exhaled. That's where kind of that real breathing happens. So respiratory bronchioles are located right at the end of the conducting zone, and that's just before the alveolar structure where the exchange of gases take place. So they're like the gateway between the airways that bring air in and the tiny sacs where oxygen and carbon dioxide get traded. Now, terminal bronchioles, those are thin and they don't have much of a cellular structure, so this makes them more flexible, which is actually great for gas exchange. They're better suited for moving gases in and out of the lungs. Now, these bronchioles don't have cilia, so you know those little hair-like structures that help move things out of the lungs, or the usual protective mucus. So this means they're more vulnerable to foreign particles like dust or pollutants. However, this also allows them to be more flexible, helping with better gas exchange. So once something harmful like dust or smoke reaches the terminal bronchioles and the alveoli, you know, that the lung tissue, it can't easily be expelled. So this is a problem because the body can't get rid of it, which might lead to complications or disease if harmful substances are inhaled. Now, around the conducting airways, so up to the subsegmental bronchioles, there's smooth muscles, and this muscle helps control the diameter of the airways, which is important for regulating airflow. Now, sometimes this smooth muscle contracts, making the airways narrower. This is called, as we know, bronchoconstriction, and it can restrict airflow, making it harder to breathe, and then that often happens during asthma attacks or allergic reactions. So to help with this bronchoconstriction, of course, bronchodilators, so thinking inhalers can be used. These meds work well on the larger airways, but when it comes to the smaller airways, below the subsegmental level, the bronchodilators are much less effective because smooth muscles don't have as much of an impact in these areas. So let's look at the alveoli. So those alveoli, they're located at the very end of the airways, so branches, 16 to 24-ish of the tracheobronchial tree, and that's where that transition happens from the conducting zone, but just from moving air in and out, to the respiratory zone, and that's where gas exchange actually occurs. So the surface of the alveoli and the terminal bronchioles is covered with tiny capillaries, and these capillaries are essential for gas exchange. So oxygen from the air in the alveoli, it moves across the capillary walls and into the bloodstream, And then at the same time, carbon dioxide in the blood moves in the opposite direction into the alveoli, where it's then exhaled out of the body. Now, these alveoli have a huge surface area, which is key for making gas exchange efficient. And that's critical for keeping oxygen levels in the blood up and for removing carbon dioxide, of course, helping us stay alive and functioning properly and all those good things. Now, the mediastinum, let's talk about it. It's basically the central part of the chest cavity, and it sits right between the two lungs. So it's packed with vital structures, obviously, that are crucial for life. We think about the heart, large blood vessels like the aorta or pulmonary arteries and veins, major airways like the trachea and main stem bronchi, and then some other important organs like the esophagus, the thymus, the lymph nodes. So sometimes the mediastinum can widen, and this can be a sign of something serious like bleeding from a ruptured aorta. That's a life-threatening situation, requires immediate medical attention. But with also a pneumomediastinum, so what that is when the air gets trapped in the mediastinal space, that's often due to trauma or injury. It can cause pain, and then it may affect how well the patient is able to breathe. So pneumomediastinum can also lead to other complications, just really depending upon the severity. Now, let's break down how the blood flows through the lungs and how this process is impacted by lung conditions. So that blood starts its journey from the heart and travels to the lungs through the pulmonary artery. And this artery carries deoxygenated blood, which is blood low in oxygen to the lungs so it can get oxygenated. So the pulmonary artery branches out into smaller arteries and then goes into arterioles and then finally capillaries, those tiny vessels where that gas exchange happens. So more gas exchange happens in the lower parts of the lungs, so in those bases, than in the upper parts. This is mainly because of factors like gravity and the way the blood flows through the lungs. Now, the pulmonary capillaries are very narrow, just enough for red blood cells to squeeze through in single file, basically. So this tight space actually helps make gas exchange more efficient, and oxygen gets into the blood and carbon dioxide moves out more easily. Now, there are some chronic lung disease implications when we talk about all of this, the lung system here. So we see polycythemia, so people with chronic lung disease like COPD or ongoing low oxygen levels, the body might produce more red blood cells to try to compensate for that, and that makes the blood thicker and can increase resistance in the vessels, putting more strain on the heart. And then right-sided strain as well. So because of the extra effort needed to push blood through those narrow capillaries, the right side of the heart has to work harder, which can lead to strain over time. And then we've talked about cor pulmonale a little bit, but this term refers to that right-sided heart failure caused by lung diseases like COPD, and it happens when the increased pressure in the lungs makes it harder for the right side of the heart to pump blood effectively, and then that leads to heart problems. So perfusion, you thought you'd already heard everything about perfusion, but there's a little bit more. So just let's dive into this and see what's going on. So perfusion, if you remember, is that process of circulating blood, through the pulmonary vessels. So key part of the respiratory system because it makes sure the lungs get enough blood to allow for gas exchange. So the oxygen gets into the blood and the carbon dioxide is removed. Now, for the body to function properly, we need a steady flow of blood through the lungs. So that helps ensure oxygen can be picked up by the blood, which is essential for keeping all of our organs and tissues properly oxygenated, not organized. So pulmonary embolism, that happens when a blood clot or other blockage gets lodged in a pulmonary artery, stopping blood from flowing to the part of the lung. And this can cause a serious drop in gas exchange, and it can lead to life-threatening complications. So some common symptoms of a PE are sudden shortness of breath, chest pain, rapid heart rate. If not treated quickly, it can obviously be fatal. And then also we can see some things with like anemia and hypovolemia. So people who are anemic, so they've got that low red blood cell count, or they're hypovolemic, they can struggle to get enough oxygen into their blood and deliver it to the rest of their body. And that makes it harder for the body to transport oxygen and carbon dioxide efficiently, leading to even more respiratory distress and potential complications throughout the system. So let's talk about the mechanisms of respiratory control. So when we talk about this, we'll talk about respiratory control and cardiovascular regulation, and those are both closely tied, and then how the heart plays a big role in the lung functions. So the lungs and the heart, they work hand in hand in this whole thing. So if there's issues with the heart, it can affect the lungs, and vice versa. So changes in the heart function can lead to problems like fluid buildup in the lungs or poor oxygenation of the blood. Now, if something goes wrong with either side of the heart, the right or the left, it can have a big impact on lung health. For example, fluid can accumulate in the lungs, which makes it harder to breathe, or the blood might not get enough oxygen to circulate through the body. Now you see, we talk about also some heart failure, which you thought you'd heard it all through cardiovascular. However, we've got a little bit more. So left-sided heart failure, it tends to get worse faster than right-sided heart failure. And this happens because the left side of the heart deals with higher pressure in the systemic circulation, while the right side works with lower pressure in the lungs. So the different pressure can affect how each side of the heart functions. Now, when we start talking about with the blood flow and this entire thing that we've been talking about, we have some blood flow dynamics. So here's how the blood flows through the heart and the lungs. So the right side of the heart pumps deoxygenated blood to the lungs for oxygenation, and then the left side receives oxygenated blood from the lungs and it pumps it out to the rest of the body, delivering oxygen to the organs and tissues. So when the body doesn't get enough oxygen, or it's hypoxic, the heart responds in some different ways. So mild hypoxia causes the heart to beat faster to try and pump more oxygen to the body. However, severe hypoxia can cause the heart to slow down, which may signal a much more critical condition. Now, if hypoxia isn't treated, it can cause dysrhythmias, which can lead to life-threatening problems with heart function and overall health as well. So we see another cause of heart failure can be some fluid imbalances. So let's talk about that. Can be some fluid imbalances, and the heart pressure, I guess is what I was trying to say. So fluid balance, the body relies on a delicate balance of fluid. So when that balance is thrown off, it can lead to fluid buildup, so some congestion and edema. So if the left side of the heart becomes overwhelmed by too much fluid, it struggles to pump effectively, leading to left-sided heart failure. And this typically causes pulmonary congestion because fluid builds up in the lungs, and then of course that makes it harder to breathe. Now, if there's increased pressure on the right side of the heart, often due to conditions like pulmonary hypertension, so that high blood pressure in the lungs, it can cause the right heart to have trouble pumping blood into the lungs. So this can result in right-sided heart failure. In this case, fluid tends to accumulate in areas like the abdomen and the lower legs. Now, when the left side of the heart has to pump against increased pressure, which can happen with conditions like high blood pressure or aortic stenosis, so that narrowing of the aortic valve, it can't pump effectively into the body's circulation. And this leads to left-sided heart failure, where the body doesn't get enough blood and oxygen while fluid builds up in the lungs. So muscular control in breathing. So let's take a look at how the muscles control breathing and then how air gets into your lungs. So breathing is a little bit like how a vacuum cleaner works. So the body creates negative pressure, basically a suction through the contraction of the respiratory muscles, and this suction draws air into the lungs. And then air enters the body through the mouth or the nose. From there it travels through the nasal passages and over the turbinates, those bony structures inside the nose that warm and humidify the air. And then it moves around the epiglottis, so that flap that covers the windpipe, and the glottis, so that opening to the windpipe. Now the body's airway is specifically designed to make sure air goes into the trachea and not into the stomach or the esophagus. So that's super important because it helps make sure that air reaches the lungs for breathing and doesn't get aspirated, which could cause choking or lung infections. So we're still talking about some muscular control and things, so let's kind of look at how the thorax and the diaphragm work together. So think of the thorax as a kind of airtight box, and it plays a key role in respiration. And it's surrounded by the rib cage, which provides protection for the lungs and heart. So not only does it support vital organs, but it also keeps them safe. Now the diaphragm is a flexible muscle, and it's located at the bottom of the chest cavity. It acts like a separator between the thoracic cavity and the abdominal cavity, so it's absolutely essential for breathing. Now when we breathe quietly, the diaphragm flattens as it contracts, and this makes the thoracic cavity bigger, and when the volume of the chest increases, it creates negative pressure, and that negative pressure acts like a suction to pull air into the lungs through the open trachea. So let's talk about how ventilation works and some injuries that can affect the chest. So minute ventilation. It's simple. Minute ventilation, just simply the total amount of air your lungs move in and out in 1 minute, and it can be increased in a couple of ways. So when you take deep breaths, you expand your lungs more fully, moving more air in and out, and then obviously if you breathe faster. So each breath is smaller, but you still increase the total amount of air moved. Now, injuries that create openings in the chest can cause air to enter the pleural space. So remember that area around the lungs, which can lead to serious breathing problems. So if there's an open wound in the chest, then air can enter the pleural space, causing a sucking chest wound. Obviously, it's dangerous because it can make the lungs unable to expand properly, and that leads to respiratory distress. And then with flail chest, parts of the rib cage break off due to fractures. So these free-floating sections of the ribs move in the opposite direction during breathing. They get pulled inward when you inhale. So this makes it harder for the lungs to expand and then reduces the overall effectiveness of breathing. Now let's look at renal status. So the role of the kidneys in this whole system, it plays a big role because it works on fluid. The kidneys work on fluid balance, so they regulate how much fluid is in the body, and then they also work on acid-base balance. So those kidneys maintain the pH level of the blood to keep it stable, and then we should know that they work on the blood pressure regulation. So by managing fluid levels and releasing certain hormones, the kidneys also influence the blood pressure. Now these kidney functions can affect pulmonary mechanics as well as oxygen delivery. So changes in fluid balance and blood pressure can impact lung function, making it breathing harder. And then if kidney function is impaired, it can affect how oxygen is delivered to the tissues, which impacts overall health and breathing. And then we see some respiratory signs in kidney disease. So people with severe kidney disease, they often experience respiratory symptoms like shortness of breath or fluid buildup in the lungs, leading to that pulmonary edema. And then there's some challenges, obviously, in these patients with CHF. So managing CHF in patients who also have kidney disease can be a little bit tricky because diuresis, so that removal of the excess fluid through urination, it becomes much more difficult, and it makes it harder to manage the fluid levels and the respiratory status of these patients. So when the kidneys can't maintain a proper acid-base balance, it can lead to hyperventilation that can sometimes look like a primary respiratory problem, making it harder to figure out what's really going on and how to treat it. So let's talk about hypoventilation and how it can affect the body. And because of hypoventilation, we start to see a buildup of CO2. So when the lungs aren't working as they should, and carbon dioxide starts to build up in the bloodstream, and normally CO2 is removed when we breathe out, but if the lungs fail to get rid of it, then things can go quite wrong. So that extra CO2, it combines with water in the body to form carbonic acid, and then the acid breaks down into bicarbonate ions and hydrogen ions. Now, the increase in hydrogen ions makes the blood more acidic, causing the pH to drop. And this leads to acidosis, which can cause respiratory distress and mess with how the body's metabolism works. So what can cause impaired ventilation? So when the body isn't getting enough air in or out, and there's several factors that can affect this, and respiratory muscle weakness is one. So we can see things like neuromuscular diseases, conditions like that can weaken the muscles that help us breathe, or obstructive lung disease, so asthma or COPD can block airflow and make breathing harder. And then central nervous system disorders. So if something goes wrong in the brain, like a stroke or drug overdose, it can mess with the brain's control over breathing. And then conditions like obesity, chest trauma, deformities, they can prevent lungs from expanding fully, making breathing harder. Now, the relationship between carbon dioxide levels and pH. The amount of carbon dioxide in the blood is closely tied to the pH of the blood. So as CO2 levels rise, the blood becomes more acidic, which lowers the pH. Now, when someone is hypoventilating, they typically experience respiratory acidosis, because when the lungs aren't getting rid of enough CO2, the gas builds up in the blood. So this extra CO2 combines with the water in the body to form that carbonic acid, which then breaks down into hydrogen ions and bicarbonate ions, which we talked about. The hydrogen ions make the blood more acidic, and then that lowers the pH. So when CO2 levels go up, pH levels go down, causing the body to become more acidic. The change in acidity can mess with a lot of body processes and lead to some serious issues. Now, when the lungs aren't working properly, even if a person is still breathing, they can't exchange gases like O2 and carbon dioxide efficiently. So this can cause CO2 to build up in the blood, and that leads to hypoventilation. So let's look at a couple of conditions that can cause this. So in these situations, the lungs aren't able to get rid of enough CO2, so it starts to accumulate in the bloodstream. And this is what we call, as we said, hypoventilation. So basically the blood can't exhale enough CO2, which throws off the balance. So some conditions that can cause hypoventilation, one is atelectasis. So that's when part of the lung collapses. So if lung tissue isn't fully expanded, there's less surface area for gas exchange, and that means less oxygen is getting in and less CO2 is getting out, and that can lead to hypoventilation. Also pneumonia, an infection that fills the tiny air sacs in the lungs, so those alveoli, with fluid or pus. That prevents normal gas exchange, making it harder for oxygen to enter the bloodstream and for CO2 to leave. And then in pulmonary edema, fluid builds up in the lungs, especially in the alveoli, and that makes it difficult for oxygen to get into the blood, which can lead to low oxygen levels and the accumulation of CO2 in the bloodstream. Then we see asthma, and that causes the airways to become inflamed and narrowed, making it harder for airflow to flow in and out. And that reduces airflow, making gas exchange less efficient, and then potentially causing some hypoventilation as well. And then we have COPD, so that long-term disease causes airflow obstruction. Now over time it damages the lungs, and it makes it harder for oxygen to enter and CO2 to be exhaled, so that can lead to hypoventilation as well. Now when we think about issues that affect the way we breathe, there's a few key conditions that interfere with how the body moves air in and out. So certain conditions can block or suppress the flow of air, and it makes it harder to breathe effectively. Here's a couple examples that you see listed. So a flailed chest, when that occurs when someone experiences those multiple rib fractures, causing parts of the chest wall to move incorrectly. So instead of expanding and contracting normally with breathing, these fractured segments, they move in the opposite direction, and that leads to inefficient breathing. And then a tear in the diaphragm, so diaphragmatic rupture. It can prevent the chest from expanding and contracting properly, and it can make it very difficult to take breaths. And then severe retractions, so when a person uses extra muscles like those neck or rib muscles to breathe, it's a sign they're struggling to get enough air, and this often indicates the airway obstruction or severe respiratory distress. And then conditions like attention pneumo, or massive hemoperitoneum, so a large amount of blood in the abdomen, that can restrict the diaphragm's movement, making deep breaths quite difficult. And then abdominal or chest binding. So tight clothing or anything wrapped around wrapped around the chest or the abdomen can limit how the lungs and the diaphragm expand, and that makes it difficult for a person to take a full breath. And then any situation that prevents the body from changing pressure inside the chest, like a blocked airway or restrictive conditions, can lead to shallow breathing or hyperventilation as well. And then our last point, you see obesity hypoventilation syndrome, or Pickwickian syndrome, you might read sometime. And that syndrome is related to severe obesity, and it affects the body's ability to breathe properly. So the extra weight puts pressure on the chest wall and diaphragm, making it harder for them to move correctly, especially when the person is lying down. So as a result, they may not breathe deeply enough, which can lead to low oxygen levels and high carbon dioxide levels, particularly during their sleep. And that makes breathing much more difficult and can even cause some respiratory distress. So when we talk about conditions that impact the body's ability to breathe or move, there are several major ones to be aware of. So you have damage to the breathing centers in the brain, and that's conditions such as head trauma, brain infections, brain tumors can cause damage to the parts of the brain responsible for regulating breathing. Now, this disrupts the body's ability to manage breathing properly, which can make it difficult for the person to breathe on their own, potentially leading to respiratory distress or failure. And then we see spinal cord injuries. So severe spinal cord injuries, especially those above C5, can damage the nerves that control the breathing. Now, when the spinal cord is damaged, the diaphragm may not function properly. So without proper diaphragm movement, then the person may not be able to breathe effectively, which can lead to respiratory function. And then on there you see the Guillain-Barré. So that's an autoimmune disorder where the body's immune system, it attacks the nerves, causing progressive muscle weakness. So if the diaphragm is affected, it becomes difficult to breathe, and if the weakness progresses, it can lead to respiratory failure. And you see ALS, so it's also known as Lou Gehrig's disease, causes progressive loss of muscle control, and it weakens the muscles responsible for movement, including those that assist with breathing. So as the respiratory muscles weaken, the patient may eventually experience respiratory failure, which is usually fatal unless managed with ventilatory support. And then botulism. So botulism is caused by a bacteria that leads to widespread muscle paralysis. And when the paralysis affects the muscles required for breathing, it can quickly become life-threatening since the person can no longer ventilate properly. And then, of course, things like intoxication and head injury, hypoxic drive, as well as asphyxia. So with intoxication, those substances such as alcohol, narcotics, other drugs, it can all depress the central nervous system. So this depression, it reduces the body's ability to regulate breathing, leading to hypoventilation and potential respiratory failure. And then head injury, traumatic brain injuries can damage the brain areas responsible for regulating breathing. So this impairment can reduce respiratory drive, which leads to difficulty in maintaining normal breathing patterns and possibly respiratory arrest. And then you see hypoxic drive. So in certain chronic respiratory conditions like COPD, the body may rely on low O2 levels to stimulate breathing rather than relying on high CO2 levels. So this can result in a reduced respiratory drive in response to elevated CO2 levels. And that makes the body less responsive to increasing CO2 and can lead to hypoventilation. Now, quick little caveat here with the hypoxic drive. This is seems to be more of a hypothesis. It's something that over the last 20 years people have torn apart, and some believe it is a true mechanism, some believe that it is not. However, if your patient needs oxygen, you give them oxygen, whether they have COPD or not. The idea is that you might overload them and then affect their respiratory drive. So once again, here's the easy one: follow your local protocols. And then asphyxia. So that occurs when the body is deprived of oxygen, and the lack of oxygen can significantly reduce respiratory drive, and then that leads to hypoventilation or even apnea. And then, of course, we know these things kind of lead to respiratory arrest. So where things don't go so pretty good, where all the breathing stops completely, and where there needs to be definitely some intervention in there. Okay, that was a lot of hypoventilation. So let's go ahead and shift gears to hyperventilation. So that occurs when individuals breathe more rapidly or deeply than required by their body's metabolic needs. And this results in the excessive expulsion of CO2. Now, of course, there's an effect on the blood pH. So, that excessive loss of CO2, it lowers its concentration in the blood, leading to a decrease in hydrogen ion concentration. And this results in respiratory alkalosis, which causes the blood pH to increase, making the blood more alkaline. Now, there's some triggers to this. Hyperventilation can be triggered by several different things. It can be anxiety or panic attacks, or there's hyperventilation syndrome, which refers to the condition where emotional triggers cause excessive and rapid breathing. There's some symptoms, obviously, lightheadedness, maybe some tingling in the extremities, due to this change. What happens is there's a change in those calcium levels, and you can get some tingling in the extremities, or even palpitations from hyperventilation. Now, that numbness or tingling, so patients, they might experience some numbness or tingling in the hands, feet, and around the mouth, and that's caused by changes in the calcium levels due to the low CO2 concentration. Might experience some chest pain, like we mentioned. So anxiety or increased respiratory effort can cause chest pain, often related to hyperventilation. And then one thing that most people have probably seen with this is some carpopedal spasms. So prolonged respiratory alkalosis can result in muscle spasms, especially in the hands and feet, leading to almost like a little claw-like position. And this is caused by those low calcium levels in the blood due to the alkalosis. Now, traditionally, patients with respiratory alkalosis have been encouraged to rebreathe their own exhaled air. So exhaled air, not hair, such as through a paper bag or maybe a partial rebreathing mask to increase their CO2 levels. Now, rebreathing air can quickly lead to a reduction in oxygen levels, and that can potentially cause some hypoxia. Prolonged rebreathing of CO2, it can exacerbate some of the hypoxic conditions, and then that may worsen the patient's symptoms because we don't exactly know why they are hyperventilating, so that may not be such a great idea. But hyperventilation can also be a compensatory response. So whenever I said it may not be a great idea, because it may be a compensatory response in patients with acidosis, where the body attempts to expel CO2 to increase blood pH and balance acid-base levels. So things like Kussmaul's respiration, so those deep labored breathing, and we see that a lot with DKA. Or sepsis and shock, and they can present with some hyperventilation as the body tries to normalize that pH as well. So in cases where hyperventilation is due to acidosis or another serious condition, rebreathing carbon dioxide is highly contraindicated. It's essential to address the underlying cause and avoid worsening the condition. So it's critical to carefully evaluate and identify the cause of the hyperventilation before initiating treatment. Sorry, my allergies are going crazy. All right, so some treatment. Sedation. Well, sedation, it may be considered in cases of true hysterical hyperventilation. That's often due to anxiety or panic. But this is generally a last resort and not commonly used in the field. So the goal of sedation is to calm the patient, but it should be approached cautiously due to the risks involved. So educating the patient that hyperventilation often occurs due to certain behaviors or situations that can help them recognize patterns. By understanding this, patients can become more aware of their triggers and take steps, hopefully, to manage and avoid them in the future. And you see some psychological support down there. So we see breathing with the patient. So, encouraging the patient to breathe in sync with you, help regulate their breathing, counting breaths, so count to 2 between each breath, and then gradually increase the count to promote slower, more controlled breathing. And then obviously distraction techniques. So engage the patient in a conversation or activities that divert their focus. And then the last one, which seems kind of fun, but I never tried it, which was having the patient sing a song. So that would be, I guess, your decision as to what song you might have them sing, but encourage the patient to sing a song or hum. It says it can help regulate their breathing, and it makes sense. It also takes their mind off things. Singing, just naturally slows the breath and encourages more controlled respiratory rhythm. So, and if you choose the right song, almost might have a little calming effect as well. All right, we got done with the A and P. Let's move on to some patient assessment. So a good respiratory assessment is more than just listening to their lungs. It's about gathering a complete picture of their entire condition. So when assessing a patient's respiratory system, you're looking at all the signs and symptoms, not just breath sounds. So you'll be checking the breathing rate, their effort, overall oxygenation, as well as looking for any physical signs of distress. Now, many respiratory conditions like severe asthma or pneumonia can escalate quickly and become life-threatening. So that's why it's so important to assess respiratory status early in the patient's evaluation. So the sooner you spot any potential problems, then obviously the faster you can act to help the patient. Now, when responding to a patient with respiratory distress, always prioritize safety by using just some standard precautions. So, these measures help protect both us and the patient from potential exposure to infectious agents, bodily fluids, hazardous materials, all those kinds of things. So things like examination gloves, some eye protection, those type of things would be a really good idea. Now, when responding to When responding to a respiratory emergency, it's crucial to assess the situation quickly and safely. So safety first, obviously. Always ensure that you're protecting yourself from potential hazards, especially when dealing with respiratory issues. So we want to have gloves, eye protection, face shield, gowns, all of those things. Obviously, mentioned it twice, safety is important. Safety first. Now, respiratory issues often come with the environment or hazardous factor, so always stay alert in the event there's something like that going on. And that can happen in enclosed or poorly ventilated spaces, like basements or small rooms where the air is stagnant, makes it harder for the person to breathe, or exposure to carbon monoxide or some irritant gases. That can cause some symptoms like shortness of breath, confusion, dizziness. So always check for signs of dangerous gases. And then some highly contagious respiratory illness. So if the patient's symptoms point to a highly contagious disease like TB or the flu, extra precautions probably are going to be necessary just to prevent that spread. So staying mindful of these factors will help you stay safe, provide the best care to our patients. All right, respiratory diseases. So, these diseases can mess with three key processes of breathing, and that's ventilation, diffusion, and perfusion. So each of these is important for getting oxygen into the blood and then removing carbon dioxide out of the body. And if any one of them are disrupted, it can cause breathing problems. So dyspnea is the most common complaint from people dealing with respiratory issues. And basically, if you're not aware of it, just a fancy word for shortness of breath. And then hypercapnia, or too much carbon dioxide in the blood, is the most common cause of dyspnea. So when there's not enough ventilation, so that air coming in and out, carbon dioxide builds up. Now this typically happens when ventilation is inadequate. So, not enough air is moving in and moving out. But some patients may actually be hypoxic without feeling short of breath. So it's one of those situations, they don't know they feel it, but it's still happening. So that's why it's always important to check the patient's O2 saturation. You might not always catch hypoxia, but just by asking how they feel. So let's go ahead and just check it. Now, if a person suddenly starts having trouble breathing, it could be due to a few different things. And we could see, like, as you see listed, an acute bronchospasm, maybe anaphylaxis, a PE, or even a pneumo. So let's take a look at those. So, acute bronchospasm, when those muscles around the airways tighten, making it difficult to breathe. So, we're thinking probably something like asthma. Or they have a severe allergic reaction that can cause the airways to swell and constrict. And then a PE, so a blood clot in the lungs, and that can make can block blood flow and make it harder to breathe. And then obviously a pneumo, a collapsed lung, where air gets into the space between the lung and chest wall, preventing the lung from fully expanding. Now, paroxysmal nocturnal dyspnea. So when a patient suddenly wakes up in the middle of the night feeling short of breath, it's often a sign of some left-sided heart failure. And in these cases, fluid backs up into the lungs, making it harder to breathe while lying down, which leads to the sudden awakening. We're still talking about scene size up, so we're kind of starting to build up our case here. And then some factors that can hinder a patient's ability to move air. So sometimes patients have trouble moving air in and out of their lungs due to various physical limitations, and it can be everything from limiting diaphragm movement to chest wall restriction, or even just disrupting the integrity of the thoracic cavity. So maybe there's damage or structural issues with the chest, like fractured ribs or a flail chest. It's a lot of different things that could be. Now, when we assess a patient, we want to make sure we're focusing on the basics. First, to ensure their immediate needs are met, and that involves a quick but just thorough check of their condition. So we want to establish and maintain an open airway. We want a formal general impression, so get that quick overall sense of what's going on with the patient. Observing their body type and the appearance can give us some clues about their condition. Here's kind of some things we can kind of look for. So with emphysema, you might see a patient with barrel chest. So that's patients with emphysema often have a rounded barrel-shaped chest due to that air trapped in their lungs. Or they might appear thinner, especially in their arms and legs. They might be breathing through pursed lips to help keep the airways open. Or often they breathe quickly, but their oxygen levels, may not be dangerously low, or show signs of cyanosis, so that bluish skin. And then people with immune system disorders, or cancer or other end-stage diseases, they often have a sickly appearance, so their body may look frail and appear significantly weakened as well. And then remember, we're talking about kind of just some signs, things that we're looking at as we form our general impression. So we could find someone, that with chronic bronchitis, and they're sedentary or obese, less active and struggle with their weight, obviously. Upright sleepers, overflowing tissues. So, they just have a pile of tissues nearby and they got stuff all up in them. And then they're spitting up secretions and a urinal nearby, and just all these things that, in the middle of the night, they're having a lot of issues. And then medications nearby. So they might have some medications or inhalers or nebulizers within arm's reach, obviously for some easy access. Now, when it comes to assessing a patient's breathing and how much oxygen they need, it's important to look at both the resting state and how they respond to exertion. So first, observe the patient's condition while they're at rest. If they seem stable, it's important to see how they respond when they start moving or exerting themselves. So when we're talking about O2 saturation monitoring, and at rest we want to measure their O2 sat, and then have the patient, if they're able to get up and walk to the cot or do something, maybe they need to climb the stairs, monitor their O2 saturation to see if it drops significantly during this activity. And that could indicate an increased demand for oxygen. Now, when a patient's body has to work harder to breathe, it can lead to a few other signs such as anxiety or hypoxia or even fever. These in turn can trigger a few different responses in the body, and we would see tachycardia, maybe diaphoresis, so some excessive sweating, pallor, where the pale skin, it can show up, which could indicate poor blood flow or oxygenation. Now, how a patient is positioned, it can tell us a lot about how they're managing their breathing. So let's talk about some of that. So to patients in respiratory distress, most of them are going to prefer sitting positions. So when someone's having trouble breathing, they'll usually choose a sitting position because it helps make breathing a little easier. So things like the tripod position. So how it looks is the patient leans forward, often placing their arms on their knees or another surface with the scapula rotating outward, so much like that young man. The position, what it does is it opens up more space in their upper lungs, and it helps drop the abdominal organs away from the diaphragm, which might make it easier to breathe. Now, although it can help, position's hard to maintain and it requires extra energy, so it might not always provide much relief. Now, a lot of times people are not willing to really lie very flat, obviously, that's having these kind of issues. So if a patient is willing to lie flat despite having trouble breathing, it could be a red flag indication that their condition is getting worse suddenly. So usually people with breathing distress find lying flat uncomfortable. So if they're doing it, something might be going wrong. And then you might see kind of a head tilt, chin lift position. So the patient may hold their head back and tilt their chin upward. So that's also known as like the sniffing position. And that position can maximize airflow through the upper airway, which might indicate that they're trying to improve their breathing or dealing with some upper airway swelling. And then we see some fatigue and head bobbing. So, a fatigued patient might exhibit head bobbing where their head jerks up and down with each breath. And this is a serious sign of exhaustion, often indicated they're struggling to maintain effective ventilation. It's an ominous sign, and it suggests that the patient might be nearing respiratory failure. Now, breathing issues can come from several different parts of the respiratory system, so it's important to know where the problem is coming from. Now, that can involve the conducting airway, so the trachea, the bronchi, the bronchioles, and that includes conditions like asthma and bronchitis, where airflow is restricted due to that inflammation or narrowing of the airways. So we know with asthma, the airways tighten up and become inflamed. That makes it harder to breathe, especially during attacks, of course. And then bronchitis, the bronchi become inflamed, and that's usually from infection or irritants, leading to coughing and mucus buildup and some wheezing. And then we have the alveoli. That's where that gas exchange happens in the lungs. So if something goes wrong here, it can really impact how well oxygen gets into the blood and how well carbon dioxide is removed. And things like pneumonia, with that infection that fills those alveoli with fluid, it makes it difficult to get the oxygen into the blood. And then emphysema as well. So those alveolar walls, they break down, and that reduces the lungs' ability to exchange gases effectively, and then obviously that's going to lead to some shortness of breath. And then you see muscles and nerves involved in breathing. So things like Guillain-Barré or even a spinal cord injury. So these conditions affect the muscles or nerves that control breathing, and without proper nerve signals or muscle function, then that breathing becomes much harder. So with Guillain-Barré, the body's immune system, it attacks the nerves, and that often affects those muscles needed for breathing. And then with spinal cord injury, if the spinal cord is injured, especially in the upper areas, so thinking like C3 to C5, it can disrupt breathing because the nerves controlling the diaphragm and other breathing muscles, those are damaged. And then you see we've got the rigid structure of the thorax, so things like a flailed chest. So the thorax needs to be rigid to allow effective breathing, but if there's trauma like the flailed chest, then the chest wall can lose stability and breathing becomes more difficult. And just remember from trauma, that flailed chest, when those multiple ribs are broken, part of the chest wall moves independently, and that makes it hard for the lungs to expand properly. Now, talking about use of accessory muscles, because we're talking about that increased work of breathing. So when a patient's using their accessory muscles to breathe, those in the neck and the shoulders and the abdomen, it can mean that they're struggling to get their breath. So these muscles help out when the diaphragm and the intercostal muscles can't keep up. However, relying on them too much can lead to fatigue, which increases the risk of respiratory failure. Now, with infants, you might notice their sternum collapsing inward when they're working hard to breathe, and this happens because the cartilage is more flexible and they're using all their muscles to help with breathing, causing bony retractions. So both infants and adults can show signs of respiratory distress with soft tissue retractions, and this means that the soft area between the ribs near the clavicles or above and below the sternum, that may pull inward as they struggle to breathe. So that's a pretty important red flag there. And then we talk about intrathoracic pressure changes. So, that's an interesting phenomenon that during inspiration, there's a big drop in the interthoracic pressure. And this can cause pulses to weaken or even disappear altogether. And that's called pulsus paradoxus. So it's a sign that the patient is under serious respiratory distress. Now, on the flip side, you'll often find that the pulses are easier to feel during exhalation. So when the pressure in the chest normalizes, this is because the blood flow is improved during this phase of breathing. Then you see we have some signs of increased work of breathing. So we mentioned those bony retractions where that sternum or ribs pull back during inhalation. And then we see soft tissue retractions. So that soft tissue around the chest, it can retract during inhalation. And then nasal flaring, those nostrils will widen during inhalation, and that shows obviously increased effort to breathe. And then the trachea can be drawn inward at the suprasternal notch, talking about tracheal tugging. We mentioned pulsus paradoxus. And then some pursed lip breathing, so exhaling through pursed lips. That's very common in COPD and asthma patients, and that just is used to maintain open airways. And then even a sound made by children with lower airway issues, thinking about grunting, that indicates respiratory distress. And then accessory muscle use, so involvement of the neck or shoulder muscles during breathing indicates some significant respiratory effort. All right, so altered rate and depth of respiration. So to get an accurate respiratory rate, we want to try to observe the patient breathing while you're doing something else, so you don't inadvertently make them change their breathing pattern. Now, even if a patient's respiratory rate seems normal, their minute volume, so that amount of the air moved in and out of the lungs each minute, could still be off if their tidal volume is too low. So here's how you can calculate it. Just a minute volume equals respiratory rate times the tidal volume. Just remember that tidal volume is that amount of air moved with each breath. Now, if the tidal volume is too low, it can mean the patient isn't ventilating effectively, even if they're breathing at a normal rate. And it's helpful to keep an eye on how the patient's respiratory rate changes over time. So tracking these trends can give you a good sense of how they're responding to treatment and whether the respiratory status is improving or if it's worsening. Now the pattern, and then let's talk about the I to E ratio, so the inspiratory to expiratory ratio. So we want to make sure we take note of whether the patient seems to be working harder to breathe, in or out, or maybe even both. So if they're really struggling, it's a sign of respiratory distress. And then unusual smells like fruity breath, that could be a telltale sign of the conditions like DKA. So make sure to keep an eye out for anything unusual. And then sometimes you can hear abnormal noises like wheezing, stridor, crackles, which can help point you towards a specific respiratory issues. So when you're listening to a patient's lungs, make sure to auscultate systematically, and that helps you cover all those areas and gets a good sense of what's going on. Remember, the left and right lungs aren't perfectly symmetrical, so the sounds you hear might be different on each side. And then some respiratory issues may change depending on how gravity affects the lungs. So if other conditions might affect both lungs more diffusely, so be mindful of these factors when you're assessing your breath sounds. So to listen to the upper lobes, focus on the front part of the chest. This is the best place to hear sounds coming from the upper regions of the lungs. And then the right middle lobe, the best spot to listen, is just beneath or slightly to the side of the right breast. That'll help you pick up sounds from that specific lobe. And then the mid-axillary line is key if you need to check for proper placement of an endotracheal tube. Listening to that area can help confirm that you're hearing breath sounds from both lungs, ensuring that the tube is positioned correctly. So we're going to talk about these abnormal breath sounds, so talking about the airflow in the large airways. Now, tracheal sounds, these come from the trachea, which is like the main highway for the air going in and out of the lungs. And then what they sound like, both inhaling and exhaling, they make loud, clear sounds. So think of them as the loudest, kind of the loudest honks on the road if we're talking about the highways. And then we got bronchial sounds. So these are made in the larger airways that branch off from the trachea. And inhale sounds are longer and louder than exhalation sounds. So, just kind of imagine a strong breeze. You can feel it, but it's not as booming as that honking is. And then the bronchovesicular sounds, these happen where the bronchi meet the alveoli. And here, inhaling and exhaling are about the same in volume, kind of just like a little gentle rustle, so noticeable but not too loud. And then we have vesicular sounds, so they come from the smaller airways and alveoli deep in the lungs. They're soft and faint with inhalation lasting longer than exhalation. So just kind of that whisper on a quiet day, just kind of nice. Now, sometimes you might hear normal breath sounds in places you wouldn't expect. So that can happen due to certain pathologies, which can change how the sound travels in the lungs. So sounds travel better through fluid than air. So if there's fluid in the lungs, it can make the breath sounds louder. Now, if there's air in the chest, like as in pneumothorax, the breath sounds can be distant or hard to hear, so more air means less sound. And then if the lungs are filled with fluid, thinking about like pneumonia or heart failure, then breath sounds will often be louder, as I mentioned. So pneumonia, heart failure, lung consolidation, those are all examples of conditions where you'll hear louder breath sounds due to that extra fluid. The quality of breath sounds can change, though, depending on how much tissue or fluid is between your stethoscope and the lungs. So it's important to know that these sounds can be affected by what's going on inside the lungs. Now, always compare the right and the left sides of the chest. So if you hear a difference, it could point to something abnormal on one side, like fluid or even a lung collapse. And then if a patient has a condition affecting just one lung or part of one lung, then the sounds might be louder on that side. So this could be due to fluid or consolidation, which makes the lung tissue denser. Now, in cases of hyperinflation, so thinking about like emphysema, breath sounds can be harder to hear because those lungs are stretched out and the air doesn't move through them as effectively. So if the patient speaks and you can't understand them through the stethoscope, it could be because the lung tissue is hyperinflated or it has a lot of air, making their voice sound muffled. And then if you can hear the patient's words clearly through the stethoscope, it might mean there's some lung consolidation, like in pneumonia or atelectasis, where the lung tissue is more solid than usual, and that makes their voice sound clearer through the chest. Now, talking about some adventitious breath sounds, so you see we talk about continuous and discontinuous sounds. So continuous sounds are sounds that you hear throughout the whole breath cycle. Wheezing is a common example of a continuous sound. And then discontinuous, these are more like little pops or snaps or clicks, we call them crackles, and they only happen occasionally during breathing. Now with wheezes, they're high-pitched whistling noises that happens when the air moves through those narrowed airways. And we have different types of wheezes. So we have diffuse wheezes and localized wheezes. So diffuse are more widespread, like as in asthma, where the narrowing of the airway is all over the place. And then localized, they happen in one specific area of the airway, maybe from a foreign object that's blocking it. So it's important to listen and figure out whether the wheezing happens when the person inhales or exhales. And that can tell you a lot about what's going on. And then with crackles, that's kind of just these little popping sounds you hear during breathing, especially when air moves into parts of the lungs that are wet or filled with fluid. So we have fine crackles and coarse crackles. So fine crackles are faint, soft popping sounds that you'll usually hear early in inspiration, and they happen when those smaller airways open up. And then coarse crackles are louder and more pronounced, usually heard later in inspiration, often in the lower parts of the lungs. And then you see we have rhonchi listed. So rhonchi is a low-pitched kind of gurgling or snoring sounds caused by mucus or secretions in larger areas. And they're like crackles, but they come from the bigger airways. Now, continuing on with our abnormal breath sounds, but you see some audible sounds include stridor and grunting and a death rattle. So that stridor, that's that high-pitched sound caused by upper airway obstruction. It's typically heard during inspiration. It often signals that something is blocking the airflow in the larger airways, like swelling or foreign body obstruction. And then grunting is a low-pitched sound that's heard with lower airway obstruction, usually associated with patients trying to force air out of their lungs, and it's often seen in conditions like pneumonia or acute respiratory distress. And then the death rattle. So this low-pitched gurgling sound happens when patients can no longer clear their own secretions, and typically heard kind of at the end of life. So it can indicate that the patient is it can indicate that the body is no longer effectively managing its respiratory needs. So as a patient's condition worsens and the sounds you hear will likely get louder, these will often indicate an increase in obstruction or fluid buildup in the airways, making the breathing effort more labored. And then if you start noticing that the audible sounds are decreasing or even disappearing, obviously that's going to be a major red flag. It could mean that the patient's no longer moving enough air to generate those sounds. So something that's often seen in severe respiratory failure. In fact, the most ominous sign is no sound at all, as it indicates that the lungs are not ventilating properly. So we see snoring. That happens when the tongue partially blocks the upper airway. It's usually heard during sleep, but it can also be a sign of obstruction in a patient who's struggling to breathe. And then gurgling, and that means there's a fluid in the upper airway, which can happen when the patient can't clear their secretions. So you might hear in cases like pneumonia or with patients who are really sick. And then stridor, so that's that loud, high-pitched sound during inhalation. Typically signals, as I mentioned, that the airway is narrowing from swelling, like with laryngeal edema. It can be a pretty urgent sign of obstruction. And then quiet breathing. So that's something to watch closely because it can mean a few different things, like hyperventilation, so breathing very fast, often in response to things like anxiety or an attempt to catch up on oxygen. And then shock, so when the body is struggling to maintain circulation and oxygenation, the breathing may get very quiet or even erratic. And then DKA, so both of these conditions can cause changes in breathing patterns. I said DKA, but also sepsis. Can change in breathing patterns where the body is trying to compensate for some metabolic issues. All right, some sputum, everyone's favorite part of respiratory patients. So obviously discoloration could mean some different things. So like blood, it might be mixed with blood, the sputum indicating something serious like a ruptured blood vessel or an infection. And then if there's a lot of frothy pink sputum, it can mean that the patient's dealing with fluid buildup in the lungs, often seen with congestive heart failure. And then some debris from infection. So, there can also be some dead cells or other debris from infections that the body is trying to clear. And then we talk about kind of just some changes in sputum over time. So fever and chills, that's probably with more sputum. So if that sputum increases and comes with symptoms like fever or chills, it's usually a sign of infection, and it could be something like pneumonia or bronchitis. And then that blood-tinged sputum, that can be a warning sign of TB, or it could happen if the patient has been coughing really hard and causing small blood vessels in the airways to break. And then if you see pink foam or froth in the sputum, often a sign of pulmonary edema. So that fluid in the lungs, it's often related to heart failure. Pretty urgent, requires some quick action. And then you have some purulent, sorry, I always struggle with that word, but think about mucus that kind of looks like pus, so it often means a bacterial infection. So the color, consistency, quantity of the sputum, it kind of gives some clues about the type and the severity of the infection. Now, breathing patterns. So sometimes when someone has a problem with their brain, it can mess with the normal way that they breathe. So the brain controls our breathing, so if something happens to it, breathing patterns can change. And we have some things to kind of look for. So any damage to the brain, thinking like a head injury or overdose or CNS depressants, that can affect the parts of the brain that control breathing, especially in the medulla, and that can lead to abnormal breathing patterns. Now, if there's serious trauma to the brain, it could interfere with how the brainstem controls breathing, and that causes irregular patterns. So what we can see is things like apneustic breathing, and it's a short, quick inhalation followed by a long pause before exhalation, and that's a sign of severe brain damage or increased pressure in the brain. So the brainstem may be under extreme stress and it's not able to regulate breathing normally. And then we can see biot's respiration, so that's that breathing is irregular with periods of breathing followed by long pauses where the patient isn't breathing at all. That's usually a sign of damage to the brain's breathing rhythm center, often caused by severe brain injury. And that's a pretty concerning sign of brain dysfunction. Anytime that you have periods of apnea with a head injury, then that kind of lets us know we're getting pretty serious here. And then we have Cheyne-Stokes. So the breathing starts with a gradual increase in depth, and then it decreases, followed by a short period of no breathing, so apnea. This kind of breathing pattern, it can indicate a severe injury as well, severe brain injury. Now in healthy people, you might see a brief apnea, period of apnea, but in patients with brain injury, the pattern can be exaggerated, and then it may reflect damage, as I mentioned, to the brain's respiratory center. So this is just kind of a breakdown of a bunch of different breathing patterns. So we see normal breathing, we have fast breathing and a lack of breathing. We have Shane Stokes, we mentioned that, where you can go from deep breathing to shallow breaths and then there's a pause. We have central neurogenic hyperventilation. So that's when you breathe really fast and deep, often because of something going on in the brain, especially the brain stem. And we have apneustic respiration. So that's, picture taking a deep breath and holding it for a moment before exhaling. So that's this pattern, and it can happen if certain parts of the brain are affected. We mentioned Biot's respirations and ataxic, so that, breather rhythm gets pretty wacky and unpredictable, usually pointing to more serious brain issues. And then agonal gasps. So these are gasping breaths that can happen in a very critical situation, like when someone's close to passing away. So it's a sign that breathing, not quite right. Now, injury to the spinal cord, and then you see polio listed as well. So let's talk about how these things can affect breathing. So the tidal volume becomes shallow. So that tidal volume is the amount, as we mentioned, the amount of air that we breathe in or in or out with each breath. And then if the respiratory muscles aren't working properly due to spinal cord injury or conditions like polio, then the breaths become shallow. And that means less air is obviously moving in and out of the lungs with each breath. So the minute volume is the total amount of the air that moves in and out of the lungs in 1 minute. So since tidal volume is shallow, the minute volume drops as well. So less air is being ventilated, so the body isn't getting as much oxygen and not removing as much carbon dioxide. Now, why it matters? Well, the body's normal breathing mechanisms aren't working well, so those patients often need some help with their breathing. That can mean mechanical ventilation like a vent, or at least some assisted ventilations to help them breathe in the required amount of oxygen and exhale carbon dioxide. And without this assistance, they may struggle with that proper gas exchange that we know that we need. Now, when dealing with respiratory emergencies, it's important to assess circulation, since it's closely tied to the body's ability to get oxygen to tissues and remove that carbon dioxide. So let's talk about the skin color. So the color of a person's skin is one of the fastest indicators of how well oxygenated their blood is. So if the circulation isn't good, or if the lungs aren't working efficiently, it can show up on the skin. So we can see things like cyanosis, that blue or purplish type skin. Cyanosis happens when there isn't enough oxygen in the blood. So it can show up as a bluish tint, usually seen around the lips, fingertips, earlobes. But general cyanosis, and that means affecting the entire body, that's a sign of some serious oxygen deprivation. And then we can see pallor, so some paleness, and profound pallor or paleness of the skin might suggest a drop in blood flow or low blood oxygen levels. It can also be a sign of shock, especially if the body isn't circulating oxygenated blood properly. Now, mucous membranes, like those inside the mouth or inside of the eyelids, can give you a quick read on oxygenation and circulation. So normal looks kind of like healthy mucous membranes are typically pink and moist, and that suggests that the circulation is good. However, if they turn blue or pale, it suggests that the oxygen levels are low and circulation may not be effective enough to oxygenate the tissues properly. Now, when assessing circulation in respiratory emergencies, there are several variations in skin color, and that can give you some insight into the patient's condition. So we talked about cyanosis. We know that with cyanosis, we can get that bluish tint seen around the lips, the fingertips, the earlobes. Now, the healthy hemoglobin levels in adults, normals typically 12 to 14 grams per deciliter. But we can also see like some dark brown skin. So I'm not going to say that word because I'll just butcher it, but you know what I'm saying anyways. So you get that dark brown discoloration of mucous membranes, or skin may occur when there's high levels of methemoglobin in the blood, and this can be caused by that nitrate exposure or even some other toxins. So this brownish color is often more noticeable in venous blood than in the skin itself. So checking those mucous membranes like inside of the mouth can be helpful. And we talked about pallor as well. So, just that reduction to small vessels. It can happen from shock, hypoxia, even cold environments, but definitely anemia and things like that. So people in shock can experience that. Now, when checking for dehydration in a patient, few physical signs that you can look for. So some dry, cracked lips, that can be a sign of dehydration. So when the body's dehydrated, it doesn't have enough moisture to keep the lips and the skin hydrated, and then that leads to that cracks and dryness. Obviously, those are going to be probably more chronic kind of things. But you can see a dry, furrowed, or kind of wrinkled tongue. That's another indicator of dehydration. Obviously, normally the tongue should be moist and smooth. So if it appears dry or wrinkled, it's probably not so pretty good, probably lacking some water there. And then dry, sunken eyes. So that's a classic sign of dehydration, especially in severe cases. When the body's dehydrated, there's a loss of fluid from the tissues, including around the eyes, and that causes them to appear sunken or hollow. So we probably, these people experiencing some respiratory distress probably need to go to the closest hospital. If the respiratory issue is linked to renal failure, it's important to transport the patient to a facility equipped to provide emergency dialysis. And then when multiple emergency departments are available, just consider, some of the following. So patient preference is a big thing, obviously. You see access to previous physician, easy access to records, all this. So feasible, transport the patient to the preferred facility, and that's provided that the distance is manageable. And that's it. That's the end of part 1. So we'll talk to you guys about part 2.